Hello, and thank you for joining today's National Press Foundation webinar about peak respiratory illness season 2025. As headlines warn of a new aggressive flu variant making the rounds, journalists need the proper context to report accurately and responsibly about access to timely treatment. Today's briefing is sponsored by the Respiratory Antiviral Alliance, a collaborative of organizations seeking to protect access to antiviral treatments that can reduce the risk of hospitalization and death. We're joined today by four speakers who can help journalists understand what's at stake during what some observers predict could be a rough respiratory illness season, and what the public needs to know to stay healthy. First, Robert Popovian is the Chief Science Policy Officer at the Global Healthy Living Foundation. He's a recognized authority on health economics, policy, government relations, medical affairs, and strategic planning. Next, Dr. Samir Vohra joins us. He is the director of the Illinois Department of Public Health. Dr. Vohra led the state through the end of the COVID-19 public health emergency, and he's now focused on efforts to strengthen Illinois' public health infrastructure. Dr. Cindy Hou also joins us. She's an infectious diseases physician and the chief medical officer of the Sepsis Alliance. Her focus areas are antibiotic stewardship, infection prevention, equity, and language access. And journalist Arthur Allen rounds out our panel. He's a senior correspondent at KFF Health News, where he reports on drugs, vaccines, and other aspects of health policy. You can read the full bios of our speakers on our website at nationalpress.org. Robert, I'd like to start with you because of your extensive research into antiviral access. A recent study on the cost of illness related to influenza noted that vaccinations seem to be dropping to levels that were last seen in the 2017-2018 season. So please give us an overview of the most pertinent data about this issue.
Thank you, Rachel. Thank you for having me. We have actually decided to do our own updated study on cost of illness related to flu and the impact of immunization on patients with regards to hospitalizations and morbidity and mortality. Um, we're looking specifically at the adult patients. There's no doubt about it that the flu itself, influenza, has a significant burden, economic burden on society. Our estimations are, and this is updated data that we are going to be publishing soon. In fact, I'm finalizing the manuscript to go on pre-publication server. Uh, the cost of illness itself is $29 billion. More than half of it, about 55 to 60%, is direct medical costs associated with influenza, and the rest of it is productivity loss. And we've estimated that based on historical data, and we've updated it based on 2025 dollar amounts. The other thing that we did with our study is to look at, as you mentioned, influenza vaccine levels were the highest in 2017, 2018, and they went down prior to the pandemic and then went up post-pandemic, and now they have dropped to historical lows again, especially for our senior patient population and adults in general. So what we've used CDC historical data with regards to immunization levels as well as morbidity and mortality, hospitalization specifically, and mortality rates. And we've looked at what happens if the influenza levels drop to historical lows again, and what would be the outcome. And we've seen that there will be significant increase in mortality and morbidity associated with that. And so far, unfortunately, our estimations are pretty much online on what we're seeing specifically related to, and I'm sure that our other panels will talk about it, regarding the new variant that is circulating with influenza in the United States, that it appears that it's not a good match for the current flu vaccine that's being administered to patients. And so our estimation is that it's going to be a significant burden on both from a cost perspective, but also humanistic perspective in the next few months.
Let's go to you now, Dr. Vohra. How does this year's activity, or what are you seeing on the ground now in terms of rates of respiratory illness?
Well, we are seeing, and as the holidays approach, our respiratory illness activity. And when we say that, we're talking about the flu, COVID-19, and RSV, respiratory syncytial virus, increasing. That for a lot of the early fall months, we were in a kind of very low limited risk period across the United States and in Illinois particularly. And now we've moved up to low. And partly we have sort of important thresholds. Typically, we say that when 3.1% of our outpatient visits are for influenza-like illness. So these kind of common respiratory illnesses, we've reached flu season. And nationally now, we are at 3.2%. So officially in this kind of flu season. I think that's also matched, as Robert mentioned, with um, less uptake of the flu vaccine, of COVID-19 vaccine, both in Illinois and nationally. And so, as this time of year happens, the weather is getting sort of cold throughout many parts of the United States. We're seeing increased illness, and I think that's when our healthcare providers, our public health departments, local, state, national, really begin getting into gear as we help support the system, put out our messaging, and for all those individuals listening and for the press as they share to the public, that's when the very important preventative measures are necessary. And for those that get sick, having access to the important antivirals to limit the severity of illness is critical.
You stated in our prep conversation that the big picture goal is to try to get people to understand that timely access is important. Are you having any success with that this season, or is it too early to tell?
Well, it is a little bit early to tell. I think we're in a place, right, where we have had our hospital admissions for those kind of three major illnesses still under 1%. Again, for context here, our seasonal peak for the flu in last respiratory season, we had about 7% of our hospital admissions be because of the flu. We had at our peak about 3% of hospital admissions be from COVID. And on both of those measures in Illinois, we're less than 1% of our hospital admissions right now. But that's why, we're using these kind of important moments around the holiday season. We had a sort of a blast sort of message go through right before Thanksgiving, planning one again right before kind of Christmas, because it's really important as we have these kind of gatherings where families come together, big groups come together, that's when illness can spread. The importance of knowing your symptoms and then having that plan with your healthcare provider so that you can get that timely access that can prevent real critical and severe illness from these respiratory viruses.
Let's go to Dr. Ho now. You shared with me that you've been spending a lot of time in schools and church basements and community centers talking with the public about health equity and access. So tell us what you're learning about health literacy as it pertains to um, respiratory illness in those settings.
Yeah, thank you, Rachel, and hi to everybody out there. So I have been spending time in the community, and it's best to build trust with folks by talking to leaders of faith-based organizations and community-based organizations, and then from there, sometimes you can get an invite to speak to the constituents. And I think, at this time, people are boots on the ground and hearing about the need to vaccinate, that the news has reports of influenza and so forth. And we know that across the world, different countries have had outbreaks of influenza and concerns to that degree. So now is really the time to take a full armamentarium of prevention efforts. And from this standpoint, I think it's important to just educate and speak in simple terms with regard to health literacy. So for instance, infographics from the CDC on respiratory vaccines can be pretty helpful about ventilating, although right now it's really cold, at least in my part of the world. And so there can be other items that you can use in the household to ventilate. Certainly, there's still importance of masking, hand hygiene, keeping our distance, having awareness of people that you're around and vulnerabilities of the individuals. So I think it's important right now to get a pulse of people in the community, to say things in plain terms. And of course, it's time to vaccinate. And so we really need everybody out there to help to dispel any concerns or questions they may have at this time so that they can become more informed citizens and be more literate about their health information.
Let's go down to Arthur Allen. You're a journalist who has covered public health and these topics, particularly COVID in recent years. What you also covered the recent advisory committee on immunization practices meeting. And so what were some of the biggest takeaways for you, and how do they affect public health messaging around vaccines?
Yeah, well, where to begin? I mean, if you're an American parent, especially, but not only in some red states, this is a very, but I don't think it really matters where you are. It just depends on how plugged in you are to science and the background and how trusting you are in the public health system. This is a very confusing situation because the messaging of the public health, federal public health, has been turned on its head. And people who are on the fringe and very wary of vaccination, for example, and other um, measures that have been proven to be safe are now running things and sending out messages that are discouraging for vaccination. At the ACIP meeting, concretely, they decided to take away a recommendation that children be vaccinated against hepatitis B at birth. And, that's believed to have saved, I mean, I've seen different estimates, but tens of thousands, if not hundreds of thousands of lives over the last 25 years that the recommendation's been in place. Now, all of both COVID, Hep B vaccines are available and still should be paid for by insurers or the governments under the Vaccine for Children program. Because the type of recommendation that they made at the ACIP did leave that open, did leave that law intact that these should be covered. But so I think the main thing so far that we've seen is just, a very negative message of vaccine skepticism coming out of the administration. And at the same time, and maybe it would be helpful for you to list some of these websites that, are providing reliable information that's more based on sort of the bedrock of research that was done prior to this year.
Before we get to that elephant in the room about the impact of COVID on vaccination uptake, Dr. Vohra, could you give us sort of a overview of the range of potential treatments and options that are available to people? You're on mute, I believe.
Thanks so much, Rachel, for that flag. Yeah, I think really important for individuals to sort of understand both kind of the preventative tools that are there to help reduce the severity of these illnesses. First of all, there is kind of a newly created COVID-19 vaccine for COVID, an updated influenza vaccine. We here in Illinois for those, for the influenza vaccine, universal recommendation for everybody 6 months and older. And then there's the respiratory syncytial virus, which there is an immunization that can be given to pregnant women during their last trimester, 32 to 36 weeks, but also for newborn 0 to 8 months, kind of other sort of immunization there. And then the COVID-19 vaccine for us in Illinois, there is, as Arthur mentioned, there were kind of differences between what the federal government through the Advisory Committee of Immunization Practices recommended and that what we here in Illinois recommended through our independent immunization advisory committee. And that is for us a recommendation in Illinois for COVID-19 vaccination for all adults. For federally, that was a recommendation for individualized decision making or shared decision making with your clinical provider. And then we followed the American Academy of Pediatrics recommendations for children, and that is a shot as recommended for those 2 years and younger. And then for those older, if you are healthy and don't have any chronic medical conditions, that is things and conversations that you should have with your provider. And then there are important kind of antiviral treatments. And so, first and foremost, for the flu, most people sort of understand that as Tamiflu. And that is something that really important to begin sort of talking to your provider because you should start that 2 days after symptoms start. And it's really important to have that kind of conversation of like when you have symptoms start. Most people don't have their at-home flu test, but to really kind of see a provider and check that out. Obviously, it's oseltamivir is the generic name, but sort of known by most as Tamiflu. There are often also other antivirals that people can use, but that's the most common. And then for COVID-19, people are generally aware of Paxlovid. That's that more kind of complicated kind of generic name combo. That's still available, an oral antiviral pill that you can take 5 days after symptoms start for COVID-19. Those things also, some people still maintain your COVID-19 test at home. We know that testing is not as sort of universally available as it was at the height of the pandemic. But testing is a really important tool because it allows you to know what illness you have and then what one of these antivirals are going to be the most effective for you. And so that's why as Dr. Ho mentioned too, the importance of this preventative, but also having the ability to test so that you can get the right medication that really works with the type of illness that you have and prevents those real severe illnesses, hospitalizations, et cetera, that can start from these respiratory illnesses.
Let's pivot now to what essentially is considered the elephant in the room. And again, that's the impact of the COVID experience on public health practice, on how the public views these topics. And Robert, I want to drill a little bit deeper on your data in that you've observed a negative correlation between declining vaccination rates and increased hospitalizations and mortality, particularly among seniors. So talk to me about what you think is going on in terms of people just experiencing COVID fatigue at this point.
Yeah, I think the COVID fatigue is also sipping its way into other type of vaccinations, right? It's not just COVID, where we're seeing reduced vaccination rates among patients. I think, frankly, there is a lot of negative. Arthur talked about the messaging that's coming out of ACIP with regards to the confusion, I would say doubts that are coming from people in Health and Human Services that are creating doubts about the vaccines. And that's coming across and it's impacting the uptake among very vulnerable patient population. We're not only seeing the drop in the adult patients between 18 through 64, but we're seeing it in seniors even that are not getting these vaccines. And to be honest with you, I mean, I've done a lot of work in the vaccines from 1990, I would say 1999 post, but the last several years, obviously it's been post-COVID, there's been a lot of discussions about vaccines, and the research clearly shows that when people like Samir go talk to their patients, or myself as a pharmacist go talk to their patients, the uptake is much better. What has happened over time is that there was a top-down government intervention with regards to mandates that really has negatively impacted the perception among patients. And we need to go back to how we used to do vaccines, which is the healthcare professionals talking to their patients about the importance of vaccines they uptake. And if we don't get to that point, we're going to have massive issues with regards to infections and poor outcomes for patients and our most vulnerable patients. You know, this is going across, we're seeing reduced uptake of vaccines even in immunocompromised people, patient populations. And there's no doubt about it. I mean, if you look at the measles outbreak that has occurred in the last 12 months in the United States, there's absolutely no doubt that the vaccination, the lack of vaccination is the cause of this measles outbreak. About 95, 96% of people who have had the measles infection across the country, not only in Texas, but across the country, most recently in South Carolina, have not been vaccinated. So again, I think that we need to go back to the basics of creating trust. The misinformation coming from very authorities that we trusted in the past is creating problems. But I think what we need to do as healthcare professionals is take the bull by the horn and be much more actively engaged with our patients in explaining the benefits of the vaccines. That's the only way I could see us getting out of this. Mandates and things like that don't work, and they backfired when it happened during the COVID.
Can I ask you a question, Dr. Popovian?
Sure.
Do you think that when you talk about mandates, do you mean childhood vaccine mandates also?
No, the childhood vaccine mandates are different. I think the mandates that occurred with regards to what happened during COVID with employment, employees,
Right.
people in the government, Arthur, I just don't think it worked. And
Mhm.
frankly, I knew it wasn't working. And you can go look at my lectures during that time. And I said, a carrot is much better than a stick. And we kept using the
Yeah.
stick on people, you know.
Mhm.
Dr. Ho, what are you hearing at the community level about whether people are just maxed out on COVID and these kinds of issues?
Yeah, I agree with Dr. Popovian that it hasn't just been COVID fatigue, but kind of vaccine fatigue. And, you know, at Sepsis Alliance, we're very much into the phrase of infection prevention is sepsis prevention. And we realize that's a totality of all these infection prevention measures, of which vaccines are still at the forefront. And so what we need to do, and what I constantly do is ask if people have had their vaccines and spend some time counseling. And so sometimes there's just a lack of awareness that they're not aware that there is a new vaccine or that they're due for a vaccine or if they qualify for a certain other vaccine. So I think sometimes that in the midst of all the information and misinformation, the people get lost in the process. So what I'm hearing is sometimes that people just need to be further educated. They really need the right influencers, whether it is their providers or sometimes it is the leaders of their churches or faith-based organizations in the communities, because it also is helpful when people have seen if the leadership, the physicians, the advanced practice providers and more receive the vaccines themselves, because then they realize that there is good for preventing infections. And really, the vaccines are our first chance, and some would say the antivirals are our second chance for getting through the respiratory season.
Arthur, during our prep conversation, you brought to mind something that was intriguing to me, and that is with this mutated strain of flu, I think it's the H3N2, um, there's concern that the vaccines that were developed aren't effective on that particular strain. Can you talk a little bit more about how that plays into vaccine compliance?
Well, yeah, I mean, I do think that overall, I mean, and it's nobody's fault. It's it's the fault of the viruses and the drift and hopefully not shift in the flu virus. But I think that because they don't always work, and they often don't work when when there seems to be a mismatch, as this year. I haven't really looked at the data yet, but um, then that's certainly a factor in undercutting confidence in vaccines. If they don't work, then why get one? I do think that in general, though, that I mean, my experience was always that older people were willing to get a flu vaccine. Just it's almost like a ritual, and I mean that may be falling away now as younger people get older, and the older people go away. But it was almost like it was like a just something that you did ritualistically, and that you felt like you were doing something for your health. And I mean, and sometimes, and you were, but I mean, how much you did, it was helping depended on other factors. But I guess it's also true with COVID vaccine that, as there were breakthrough cases and then they weren't in many age groups, overall, obviously there's exceptions and people who got very sick at different ages, including kids. But as the vaccine didn't seem to be preventing infections, and most of the infections weren't that serious, that obviously undercut confidence in vaccination too, to a degree, I'd say.
We have a question from one of our attendees for Robert. Can you share more about your recent study about people with chronic conditions and COVID? Um, I guess you could also speak about, in general, uh, the importance of people with compromised immune systems
Right,
access.
right. So the current study that we're doing is irrespective of, we're just looking at age groups, right? It's irrespective of chronic disease because CDC just doesn't have that level of data specificity. So we looked at different age groups and the vaccination rates. But we've done studies in the past looking at specifically chronic disease patients. At Global Healthy Living Foundation, all of our patients have chronic diseases, and not only they have chronic diseases, they're all immunocompromised. So over time, we have done multiple surveys and also studies of our patient population regarding uptake of vaccines and uptake of antivirals. And actually, I want to go back to what Dr. Vohra was talking about with the antivirals and up to Dr. Howe, is that what we're seeing is that, for example, we did a large survey of about a couple of thousand people earlier this year on Paxlovid and the uptake for COVID. And what was interesting is that, remember, 100% of our patients are chronic disease patients, 100% of our patients are immunocompromised. About 95% of the people who we surveyed were very much aware that there was an antiviral available. So these were positive patients. First of all, we asked them whether they got, the last 2 years, they had a positive test result for COVID. They were aware of the antiviral. They showed up to the physician's office and only 50% got the antiviral prescribed to them. And majority of the time, the feedback from the healthcare professional was that the disease is not severe enough for me to prescribe it, which raises the question that, again, these are all immunocompromised patients. So how severe does it have to be before they get prescribed? So there's this massive educational need, I think, on the healthcare professional side too, of when you prescribe these drugs. If we were talking about the general population, that may make sense, but not the skewed population that we were looking at in GHLF. So I think what we're seeing is, again, my worry is that not only we're having this uptake reduction overall, but that the uptake reduction of vaccines and antivirals and things is happening in the critical patient population that really requires them. And I want to go back to one other thing that I mentioned. I think and I mentioned it early on, yeah, there may be a mismatch of virus and nobody's fault, right, about the vaccine. But there's also the truth that getting the vaccine reduces the burden of illness. That's another thing, messaging that we don't give enough to patients, is that you may still get the flu, you may still get the COVID, but the burden of illness will be significantly reduced, and we continuously don't focus on that as much as we should, I think.
Hmm. Yeah.
That there's This is actually a really good point to pivot to a discussion about health equity, because it's one thing to say, yes, make a plan with your healthcare provider, but if you don't have a healthcare provider, what do you do? And Robert, during our conversation, you mentioned your research that said 90% of adult vaccines are administered in pharmacies,
Yeah.
particularly in underserved communities. So, Dr. Vohra, talk to me a bit about how your department deals with that issue of equity and access for large populations of people who may not have health care.
Yeah, and I think this is a great sort of point, Rachel, of like how we're also at a moment where how we think about healthcare access is changing because of the disparities in access that we have, but also this kind of really important statistic of the ability of pharmacies to sort of fill that void at times. And I think we are seeing a lot of that sort of encouraging some of those connections here in Illinois. A lot of conversations between the health department and our healthcare providers because, as mentioned, the education gap is beyond just resident, right? It's also with the healthcare community, but opening up different types of access points. So we just and Governor Pritzker just signed a law here in Illinois early in December that was part of codifying and putting into legislation an executive order that he signed in September around really thinking about statewide vaccine access. And part of that one was allowing our state regulated insurers to follow Illinois-based vaccine recommendations, but also allowing pharmacies to provide vaccinations outside of the regular kind of school immunization schedule for individuals as low as 3. We also put into effect the Illinois Vaccine Access Program to provide funding and the ability of local health departments to get vaccines and provide them to their community for individuals as young as 6 months to sort of fill that gap that we see also in pharmacies. And part of this is trying in as many ways as possible to increase access points. We've also partnered with different groups to provide funding for mobile clinics to get the health delivery out into the communities that might not be able to access a provider. You know, as a practicing pediatrician before I became Illinois state health official, we know that there is great importance in that medical home, having a provider that understands you. But we also have to meet the moment and the realities of trying to get these important services to people in communities where they need. You know, our nation is big, diverse. Illinois is big and diverse. We often think about Chicago being a hub, but a lot of rural areas. We know that many of these illnesses, of course, those that are immunocompromised over 65 as well, but they hit a lot of Black and brown communities, rural communities, deeper, more extensively. And so that is to that conversation we discussed before about trust, but it's also trying to meet them where they are. Pharmacies have been a real opportunity to provide access, but mobile clinics, and then allowing the state to put forward different programs in partnership with our local health departments to really improve as many access points as possible.
Dr. Ho, you have talked about the need to confront vaccine hesitancy by perhaps engaging the support of faith-based leaders and community leaders in different areas. So, talk about how public health officials can gain their buy-in.
Yeah, I mean, it starts with for public health officials to sometimes partner with other folks, for instance, hospitals, urgent cares who might know the faith-based organizations or the community-based organizations. So you can't just kind of show up. And it's really a long haul, the long game. And insofar as what Illinois has done, that's amazing because you're creating like a vaccine neighborhood, so to speak, with all the mobile clinics, all the pharmacies, and so forth. So I find that once you network and continue to show up at community events and talk to people, then you gain trust and buy-in. And this is just critical because we need to reach people in all sort of niches wherever they are, whether they're in rural locations, especially with maybe hospitals closing these days, fewer providers, then sometimes we need to find people in the communities that they are in. And we also need to be aware of information that's in plain language. So for instance, Sepsis Alliance has a website on the flu. It's called sepsisandflu.org. It has language that talks about influenza. It's very plain speaking. It doesn't really mention the antivirals, probably just to, but from aside from that, it has very good language about influenza that anybody can learn from. So that's also another resource.
Arthur, one of the biggest challenges for journalists is that, when your editor sends you out to cover these kinds of topics, obviously, morbidity and mortality get more headlines than just a day in the life. And so, what advice would you give to journalists, particularly in this moment when organizations like CDC and HHS are undergoing so much flux? What advice have you followed in terms of getting the best information and trying to develop stories that do more than just create panic?
Um, well, I mean, I think it's always helpful to talk to patients and to families, when you're reporting on these issues and bring it to a human level, along with, the data and the trends that we're seeing and that we report. I mean, it's true that, I mean, I think a lot of our mission as journalists these days is to sort of, I don't know if it's raise alarm, it's just reporting what's going on, which is alarming in a lot of ways. And so I don't think we can, prettify that exactly. I think we need to rely on experts, trusted sources, and also just, consider everything as fairly as possible, no matter what we're reporting. Um, could I ask Dr. Vohra a question about access? Because that's really interesting what you were saying. And I was wondering, does do have the has immigration activity, ICE raids and so on, affected attendance at clinics, whether they're, public health, mobile clinics or schools or whatever that you've seen this year?
Well, maybe I can speak more broadly. Of course, in a sensitive issue like that, it's very difficult to kind of track any kind of, let's say, objective data. But
Right.
as has made kind of national news, there's been a lot of focus around ICE raids in the city of Chicago. Our governor has been leading bravely there, and we know that when we talk to sort of communities that are fearful of coming out into the public and seeking care.
Right.
That's been a place where people are going to stay home, right? And I think
Yeah.
there are moments, and there's been work in our General Assembly, again, recent legislation to sort of work with hospitals to provide a policy around how to make the access of care as safe as possible. But we are in a position right now where there are trust deficits, as we've kind of talked about. but those extend beyond just, whether or not you want to get a vaccine. It's like, do
Yeah.
you feel safe um, to go out into public to get the meaningful care that you need? And we we need, I think, sort of globally understand that like these sectors of society do intersect all the time, right? And when there's a loss of a trust in an institution, whatever that institution, sometimes that sort of extends. And there were many times, I think, as a pediatrician before being, the state's kind of health leader, you thought that maybe healthcare was in a bubble, sort of protected from some of these outside influences. But it's become sort of this lack of trust in institutions, your own personal safety. And those things then lead to, I think anecdotally, we've heard from a lot of our organizational community leaders across the state that it's preventing people from getting kind of the basic care that they need, health included.
Mhm.
Dr. Ho, I see a Zoom hand. Did you have a?
Uh, yeah, I just find this conversation interesting. I was just gonna add that I agree anecdotally, people are maybe not seeing their providers for their usual care. And I think this raises the importance of going a little bit old school, meaning old school house doctor calls, going to the places where people live. Not every institution will do that. It also may entail unusual kinds of outreach with regards to vaccinations, such as if you can find a pharmacy or a pharmacist that's able to uh, get shots in the arms at the person's home. And honestly, it's not just when in cases of people who are immigrants, but also people who are sheltered in place by virtue of their body habitus, social determinants of health, where they don't have the transportation and more, which also speaks to unusual modes of communication or usual modes of communication that were one of the bright spots of COVID, I think, was bringing up to speed better attention to the public for telemedicine, for which there is a certain benefit from that. And at least you're still connecting with your provider. So I would suggest those kinds of modes as perhaps additional opportunities for us in reaching people who are vulnerable, whether they are immigrants or whether they've been here as naturalized citizens or citizens. And so it's an opportunity for all of us.
Well, because one of your areas of interest is language access, talk a little bit more about the need to sort of convey information in ways that everyone understands without, dumbing it down too much, but it really gets across to the people who need to hear it.
Yeah. Well, we are a nation of many different languages. There are probably over 22 million people or so that have limited English proficiency, which means that they don't necessarily have the exact ability to read, speak, or understand English. It's very limited in their command, yet that doesn't mean that we can't convey their information. And we call this delivering your health in your language. And so we already struggle with people who speak English, let alone for people who speak different languages. And through this all, we can't also forget people who don't have the ability to speak, but may utilize American Sign Language. Did you know there's also dialects for American Sign Language? I had no idea until recently. And so the information that we can convey, as we talked before, is in plain language, but it's also should be in commonly spoken languages of the areas you're trying to serve. So you might imagine that if there is a place with a high concentration of different languages, then in order to tell people of the antivirals that exist in the first place, then that information might need to be translated into the formal primary languages for who you're trying to reach. And I feel that this is very important, and because this is a concern where if sometimes in certain households of people with limited English proficiency, especially if there are If a household has many individuals, then certainly respiratory viruses could spread very quickly, and we want to inform everyone of what is available as far as infection prevention, as far as vaccines, antivirals, and more. We can't begin to do that if you're not saying the same language. So I feel that's really important, and we can partner all over the place to do this and not reinvent the wheel, because there are certainly organizations that have printed information in different languages.
Robert, you have suggested that states might need to detach themselves from ACIP due to some of the inconsistency in recommendations, and that I think you said you plan to meet with some attorneys general to address this topic. Tell us a little bit more about that.
We saw what happened when with COVID, the latest iteration of the COVID vaccine, right? So the Health and Human Secretary came out, made some comments about how there's going to be differences. FDA came out with its labeled indication that was very different. In fact, and during that time, there was a lot of confusion about what's going to happen with regards to ACIP. And that's when the governor of Illinois, several other governors in the states, both red and blue, by the way, had to step in and have these directives that allowed pharmacists to immunize, because pharmacists' ability to immunize is attached to ACIP recommendation in many states. Now, I have to say, Dr. Vohra talked about it. I want to go back to a state that I'm licensed in, which is California. California recently, Governor Newsom passed a legislation, signed into law, that said pharmacists no longer need to follow for vaccination any kind of ACIP requirements or any requirements. It's standard of practice, basically. Just like physicians do it or based on nurses, it's a standard of practice thing. So, in my opinion, states almost, because of this uncertainty with ACIP of what it's going to do, because you never know what's going to come out of that committee, whether or not they're going to recommend something, not recommend something, it's going to create confusion in the state level. You almost have to create a bubble where you start removing yourself from these ACIP recommendations. And it's not just about the pharmacist immunization, by the way. In almost all Medicaid programs in the country, the payment for Medicaid is attached to an ACIP recommendation. So if an ACIP recommendation doesn't occur, physicians, pharmacists, nurses, whoever is giving an immunization is not going to get paid for Medicaid. Therefore, guess what? They're not going to be administering for that patient population, which is a very vulnerable patient population. And a lot of states also, insurers base it on ACIP recommendations. So in my opinion, what has to happen, ACIP has to become almost like a recommending body, but through legislation in the states and policy and regulation in the state needs to start detaching itself from both an administration level as well as payment level from ACIP because of this uncertainty in this body.
Dr. Vohra, it feels like yet another layer of complication and things for you to consider as you're dealing with this issue. But tell us about what you're thinking in Illinois.
Yeah, and I think, as Dr. Popovian mentioned, uh, a lot of this is the fact that for decades, the Advisory Committee on Immunization Practices was a trusted source that practiced gold standard processes, scientific processes to make decisions, independent of, let's say, sort of agendas around vaccines in general. Looked at the evidence, was critical. I think part of, for me, both as a physician, as the state health official, as a scientist too, that science is not static. Science changes and evolves, but done through these objective, independent processes. Part of, through Governor Pritzker here in Illinois' leadership, we have wanted to maintain that ability of credibility, transparency, evidence-informed and scientific processes. And we were fortunate in Illinois to have an already statutorily created immunization advisory committee. And what we did through this process is that we bolstered it with the leading experts in Illinois who are national and international experts in pediatrics, OBGYN, public health, epidemiology, immunology, infectious disease to provide recommendations to me. And then similar to California, now we have legislation that allows us to move forward around those recommendations. But would I say as a state health official that this is ideal, that we want these 50 different state solutions? Absolutely not, because we know that these diseases, they cross borders. We practice, right, often across, multiple states too, and to have one body, a consensus body that was looking at that evidence for the entire country to set policy was a gold standard that as a pediatrician and now as a public health leader made a lot of sense. Fortunately, we are talking a lot to the specialty societies, to other states to try to sort of build what we think is in the is following that process so that we can provide recommendations that our residents can trust. But, as Arthur and our other panelists mentioned, that just leads to a lot of differing information. Um, and in a climate where we know that people are not often getting their news and information from newspapers anymore, we know the influx of social media and how that's sort of translating information. It's really difficult to wrap our arms around this as any individual body. And so, to Dr. Popovian's, I think, really strong point earlier, we have had messaging to the public, but that also really worked to messaging to our healthcare providers because we know that some of the on the ground messaging, people that you worked with and you grew older with, I would always talk about as a pediatrician is that people were trusting me with uh, the care of their child, the most important thing. And I had to say stuff, over especially those first couple months where they're like, oh, that guy was right. I should listen to him more because it built that trust. And I feel the same responsibility as the state's health leader. We have to be out there. We have to show and continue to prove that we are using evidence appropriately. We're doing this credible. That's why our immunization advisory committee, we actually have a meeting of it later today on December 16th to talk about the hepatitis B vaccine. They're open meetings that anybody can kind of come to, ensuring that we are doing this thoughtfully and credibly so the public can trust us. That is a intensive process, but more meaningful because we will need to continue and maintain building this trust. It will not be kind of done and solved in any one particular moment. And these federal changes and federal uncertainty means that this will be a big charge for public health, probably in the many, many years to come.
We are near the end of this incredibly informative discussion, but I wanted to give each of you the opportunity to share with journalists a sort of top of mind or top line message. And I think for Robert, based on my conversation with you, one of the things that jumps out is you said that it is a lot easier for members of the public to obtain medications like Ozempic versus vaccines. So, what top line message would you give to journalists about the need to report on access issues?
It's incredibly important. I mean, I just had a family friend who came to our house and wanted to access one of the GLP-1s. Within 24 hours, the GLP-1 was at their doorstep. Okay? We need to create an environment where patients who want medicines, who want healthcare, are able to access it quickly, very minimal interventions and hassles that they have to go through. And I can't imagine a more important intervention in healthcare, the most cost beneficial intervention in healthcare, which is immunization, vaccination. We need to make it easier and easier and easier for the public to access these things. We cannot create these artificial barriers, whether it's the state laws, regulations, or federal uncertainty, that creates this environment that patients are not accessing them. So in essence, we need to go back to the basics and think about what is the most important intervention in healthcare. To me, it's immunization, the most cost beneficial one. As an economist, I can tell you it's the most cost beneficial one. And we need to make it much more accessible than ever before.
Dr. Ho, if I had to speak for you, it might be that your message is infection prevention is sepsis prevention, but in general, prevention is key.
Absolutely. Though we've talked a lot about vaccines and antivirals, of course, those are very important, but we cannot forget the totality of the package. That if you understand that most respiratory viruses, it could be spread through the cough, through some contact, and that's how we can protect ourselves. There's still a critical importance of the mask, especially in vulnerable populations, especially if you're going to, like a doctor's office or other places where there's a high density of people who could be sick. Then we can use the general surgical masks. There's the K95 masks, which are a little beakier but roomier, and then of course the N95, which are sometimes too expensive. We certainly can make those more affordable. Ventilation, hand hygiene, these are just critical. Having an awareness and speaking to others and being an advocate for yourself, your family, your community are also really important because it takes a village, as they say.
Arthur, tell us a little bit about your advice in terms of a strategy for journalists who want to cover this issue.
Well, I think you have to get your information from good sources, and it's always good to read studies carefully. And if you don't understand something, to ask someone to explain it to you. And I mean, I don't know. There's a lot of low-hanging fruit for journalists these days, I think. Um, I don't know. Sometimes it's hard to think about, what would be the most use to the public. I mean, as journalists, we kind of don't always think that way. We're just more I mean, as you said, sort of if it bleeds, it leads, and that's very true of what's going on now in the government. But I do think it's important to try to provide really clear information and not, over exaggerate, not exaggerate things that are happening that could be threatening to public health.
And Dr. Vohra, you've done a fine job of telling us what Illinois is doing to prepare, but are you anticipating a surge, and what are you doing to
Yeah,
prepare for that?
I think we are worried, right, a little bit about flu this year more than the others because of the new variant that you mentioned. Uh, but I think some of the things that we kind of lean into that the COVID-19 did teach us how to deal with these respiratory surges. We're having conversations with our hospital leaders, our public health leaders, and continue to sort of message out to the public the importance of vaccinations, the importance of antivirals, and to the press here and journalists to help tell the truth and stories to make people as healthy as possible, right? And I think those are the things that we want to partner with you on. We want you to hold us accountable to doing that. But at the end of the day, the goal for us in the health professions is to make our patients and residents as healthy as possible. And that requires communication and being able to tell meaningful stories effectively. Sometimes that can get lost in numbers, but doing that in meaningful, important ways can make the state of Illinois and our country healthier, and that's the continued goal of my work here in Illinois.
And with that, we have reached the end of this webinar about access to antiviral treatment during this peak respiratory illness season. Once again, I'd like to thank our panelists, Robert Popovian of the Global Healthy Living Foundation, Dr. Samir Vohra, Director of the Illinois Department of Public Health, Dr. Cindy Hou of the Sepsis Alliance, and Arthur Allen of KFF health news. On behalf of NPF, I'd also like to once again thank our sponsor, the Respiratory Antiviral Alliance, for sponsoring this opportunity for journalists to better educate members of the public about ways to protect their health this winter.